All right, good afternoon, everyone. We're going to start right on the dot today. My name is Sasha Beatty. I am Deputy General Counsel at the Association of Prosecuting Attorneys. APA is a private nonprofit located in Washington, D.C., serving prosecutors as well as their law enforcement and community partners. This webinar is in partnership with the Center for HIV Law and Policy, or CHLP, without whom this webinar would not be possible. Points of view or opinions in this presentation are those of the presenter and do not necessarily represent the views of APA or CHLP. Now, just some very quick housekeeping before we begin. If you have a question for our presenter throughout this presentation, please use the questions widget, which is on the right side of your screen. We typically hold questions until the last 10 minutes of the presentation or so, at which time they will be read aloud to our presenter and he will address them. And in the meantime, if you're having any technical difficulties or questions, you can pop into the chat box, which is also on the right side of your screen, and let us know. And one of us will assist you with any sound or quality issues that you may be encountering. And now with that, I am going to turn things over to CHLP's Jada Hicks, who will say a few words about CHLP and introduce our speaker today. Jada?
Thank you so much, Sasha. My name is Jada Hicks. I'm a supervising attorney of criminal justice initiatives at CHLP. The Center for HIV Law and Policy challenges barriers to the rights and health of people affected by HIV through legal advocacy, high impact policy initiatives, and creation of cross-issue partnerships, networks, and resources. We support movement building that amplifies the power of individuals and communities to mobilize for change that is rooted in racial, gender, and economic justice. Today, I have the distinct pleasure of introducing Dr. Wohl to our webinar. And Dr. Wohl is a professor of medicine in the Division of Infectious Diseases at the University of North Carolina. He is co-principal investigator of the Global UNC Infectious Disease Clinical Trials Unit and site leader of its Chapel Hill research site. Dr. Wohl is a clinical scientist with a focus on emergent infectious diseases, and he has spent over 20 years leading research into the prevention and treatment of HIV and served 2 terms as a member of the U.S. Department of Health and Human Services on the antiretroviral guidelines panel. He also has an active clinical practice at UNC. Without further ado, Dr. Wohl, if you could take it away.
Thank you, Sasha. And I'm going to just share my screen. Hopefully you can see it. Perfect. Well, thank you. Thank you, Sasha and Jada. This is really just a pleasure to be here again. It's been a little while since I've done this, so I'm glad to be back. So I'm going to just minimize that for the moment. So as was mentioned, I work at the University of North Carolina, and I'm a professor of medicine and infectious diseases, and been really most of my career focused on HIV. Over the last 4 or 5 years, been looking more at global infectious disease threats, including Ebola and other viral hemorrhagic fever. And then, like most people in my profession over the last year, really everything has been subsumed by COVID-19. So we're going to talk about HIV transmission, some of the science behind it, and also I'll touch upon some of the same foundational principles that apply to other infectious diseases, including COVID-19, given we are seeing now some cases where folks are being prosecuted and convicted for trying to potentially spread COVID-19. So there are some parallels as we talk about HIV to other pathogens. Okay, let's go to the next slide. So there'll be plenty of time for discussion and questions, and I really do hope that you'll take advantage of that. So there are 3 and only 3 routes of transmission of HIV, and I think these are pretty obvious to most of us. I think pretty much everyone can get 2 out of the 3. Blood and blood products. This is a virus that disseminates widely. It's mostly in our cells, in our lymph nodes, the immune system cells. But it traffics between places through the blood. That's its highway. So we can find the virus readily in the blood, and this is infectious virus. And that's where we can see transmission occur when people share injection works, or there's transfusions that are not screened, etc. So we know that blood can do it. Of course, sexual contact is the #1 way that HIV is transmitted across our planet. And this requires some contact with a mucosal surface. A mucosal surface is basically a shiny surface. When we think about shiny surfaces in our genitals or our mouth, this is where HIV likes to, can transmit and actually enter. Surfaces that are matte, are not shiny, have a layer on top of them. We just don't see that kind of transmission occur. So we're talking about penile-vaginal contact, anal contact, possibly oral sex. The data on that are really flimsy, but it's theoretically possible. But eyes, mouth, less so, because there's just not as much of that kind of surface. And also, we just don't see cells there that are as receptive to the virus as we see in the genitals. And we'll get more into that in a minute. Vertical transmission refers to transmission from a mother to her child, and that can happen prior to birth or during the birthing process, or even postnatally with breastfeeding. So those are the 3 routes that we see transmission of HIV. So if it's not there, it's not a transmission route. And so it's really important for us to think about when we think about what is possible and what happens as far as HIV transmission. This gets back to some of those principles of transmission, and this holds pretty much for everything we can talk about that is an infectious disease. So in real estate, it's location, location, location. In infectious diseases, it's inoculum, inoculum, inoculum. Inoculum is the concentration of the virus or the bacteria or the fungus or whatever pathogen it is in the substance that is being considered potentially infectious. So with HIV, the amount of the virus that's in a fluid that we're talking about really matters. Because if it's a needle in a haystack and there's very little of it around, it's not going to lead to infection. Just the odds are so against it. It's analogous to all these studies that look at your kitchen surfaces and they find E. coli on your sponge and on your countertop, but we don't get sick because you can find 1 or 2 or maybe a 10 or maybe 1,000, but there's not enough of it to lead to a risk of one of those getting into you, reproducing actively, and then causing havoc inside of your body. And you need a sequence of events to occur for transmission to occur effectively, for infection to occur. One simple HIV virus in your system getting into your body probably will not lead to HIV infection. The odds are against it. It's survival of the fittest. You need a concentration of virus that's sufficient in order to actually get transmission. There are certainly characteristics of the virus that can lead to infectiousness, and we've all become well versed in this because with COVID-19, we all understand that there's these variants. So the variant we had early on was not as transmissible as the variants we have now. So we've been schooled in this principle, and the same thing can happen with other things like HIV. But by and large, HIV that we think about, especially here in the country, is pretty homogeneous, pretty monolithic, and it's all about as infectious as any other HIV that's around. But with some viruses and some pathogens, that changes over time. So we have the inoculum, we have the characteristics of the virus that may make it sticky or not sticky, or have a better predilection for a surface versus a different surface, such as in Africa, we see a lot more heterosexual transmission because of the tiny nature of their virus, a little bit differently than here. Susceptibility is the other side of the coin, because if you have an infection that is being transmitted to somebody who already is immune to it, either because of natural resistance or acquired resistance, like with vaccination, it's not going to lead to transmission effectively, right? So infectiousness and susceptibility, you need both. And when we talk about HIV, you'll see that there are some things that can change this over time. So when we look at infectiousness, how do we measure that? Well, we can look at the virus level in the blood, this viral load. And now again, COVID, I think, has given everyone a crash course in infectious diseases. We can use a PCR test. PCR is what is used. It's a type of genetic sleuthing and quantification that we can use with a swab of the nose to look for COVID-19. We've been using PCR for many, many years to look at the virus level in the blood and quantify how much HIV is in a drop of blood. And of course, the more HIV you have, the more infectious you are in general. There's also things that can also lead to more infectiousness because they provide portals for the virus to be transmitted from one person to another, such as an inflammatory sexually transmitted infection. So if you have gonorrhea or chlamydia, you're more likely to see cells recruited to combat that infection, and those cells, if you're HIV infected, could carry HIV, thus delivering more inoculum into the fluid that's a cause of concern. We'll talk about it in a second, but acute infection means soon after somebody acquires HIV, the level of HIV goes sky high and then starts to go down as the immune system fights back. So we know people very early on in their HIV infection are teeming with the virus. And when I say early on, I mean matter of weeks, not months. Over the first 2-3 weeks, the amount of virus can be in millions per drop of blood. And then we can also think about, and we don't measure this as much, but maybe there's a little bit of a disconnect. What's in the blood may not be in the genital tract, although they mirror each other. But there's also theoretically a way to look at genital tract viral load, and that can also tell us infectiousness. And like I said, with inflammatory sexually transmitted diseases or herpes, we can see that the genital tract viral load could be artificially elevated, even beyond the blood viral load, because of the recruitment of immune cells that can be infected with HIV. And then again, on the other side of it is susceptibility. And some of these same things can lead people to be more susceptible to being HIV infected. So that if you have a genital ulcer, you can imagine that breakdown of the skin, that matte surface, could lead to a portal of entry. It's just open right there. And so HIV can easily get into the blood vessels that are being exposed in the ulcer. Again, inflammatory STDs, the taxi cabs now are not chock full of HIV, but they're there to fight this STI, and then HIV comes along and those inflammatory cells are susceptible to HIV infection because those are the types of cells that HIV likes to infect. Lack of circumcision. So circumcision not only influences susceptibility, but also probably infectiousness. There is an inflammation around the foreskin, and again, those inflammatory cells can carry HIV. When someone is circumcised, there's not that inflammation, there's not that shiny surface, and the end of the penis really becomes much like an elbow. You know, you start to see this matte surface that HIV doesn't penetrate into very well. Cervical ectopy has to do with the cervix of girls and women, and there is an area of an interface between the vagina and the cervix, and that zone can lead to susceptibility to HIV because younger girls, that zone is more exposed on the cervix than over time where it gets more involuted into the cervix. And then there may be some genetic differences that lead to people to be more susceptible. So theoretically, there's things we have to think about on both sides, infectiousness, susceptibility, but for practical purposes, it's going to come down to viral load. How much virus is in the person who's infected, and does that lead, does that cross a threshold that leads to infection to somebody who's not protected? Now, there are ways to influence both infectiousness and susceptibility that we'll talk about, and both of these have to do with biological interventions, medicines. So there are medicines, as we all know, that have revolutionized the care of HIV. Lifespan for people living with HIV now is measured in decades. It's no longer the quote unquote death sentence it was. People could live healthy, productive lives. In addition, the medicines that we use drop the viral load in the blood and the genital fluids down to such a low level, it is like a needle in a haystack. That's what we call undetectable. And that renders someone really not infectious. And that's important. So we'll talk a little bit more about that in depth in a second, but medicines that are effective at reducing HIV viral load in the blood decrease the viral load in the genital tract commensurately, and we see that people cannot infect other people. There's also medicines similar to what we use to treat HIV, if not identical, but less of it. So pared down, or HIV treatment light, that reduces susceptibility substantially as well. So it's like a chemical condom. It prevents people from becoming infected with HIV. So on both sides of this coin, we have interventions that have really changed the dynamics between infectiousness and susceptibility that existed before we had these interventions. So talking about unmedicated people is going to be really important, because when we talk about people who are HIV infected, who are on medicines to lower their HIV viral load. That's different. And when we talk about a person who's on medicines that are designed to prevent them from getting HIV infected and they have an exposure, that's different than when we're talking about a couple, a dyad, where one person is HIV infected and one person is not. Neither one of them have any medicines on board. So when we talk about that, which was the situation for decades up until, last 10 years or so, the average risk that we can assume comes from studies of large people, so observational studies of people, some in the United States, but mostly in other parts of the world. But it's very hard to translate some of these observational data to individual cases, except really at the extreme of when we do not see much HIV around. Once you get down to a low level of HIV, we just don't see transmission. But beyond that, low level virus and then going up and up and up, it's very hard to quantify that. When someone's viral load is X, we know that they have Y risk of transmission or odds of transmitting to a susceptible host. So what are some of the things that influence us, and why is it so kind of fuzzy? Well, it also depends upon the type of sexual activity. There is a hierarchy. Like I said, oral sex just seems to be a very inefficient way to transmit this virus, whereas anal sex is probably the most effective and most efficient way. And that has to do with the surface that's inside of the rectum and anal area and how many cells are there that are really susceptible. These are cells, inflammatory cells, immune cells, that are there to keep us from getting sick from the germs in our GI tract. So these cells are just there normally, but they are the target, part of the target for HIV. So it makes some sense. Also, anal sex can lead to more micro trauma, or even more than micro trauma, leading to bleeding. And just like we talked about, herpes ulcers can be a portal of entry. So that's why anal sex is much higher risk than some of the other types of sex we're talking about. Vaginal sex comes down in between, where we do see, of course, again, transmission from men to women. And again, the surface of the vagina is such that we can start to see transmission of the virus and passage of the virus, especially at the end of the cervix. It's not so much in the vagina. We think it actually is the cervix. But of course, there can be other areas where with abrasions or ulcers or infections, we can see transmission in other parts of the vaginal tract. We also talk about receptive versus insertive, so top or bottom, if you will. And obviously, when we think about a person who's on top being infected, it's different than when a person on top is not infected and the bottom is infected. And that can also change the odds of transmission. If somebody has HIV and is a bottom in anal sex, there is virus in the rectum, but whether or not that virus can really jump to the penis of the person who's on top, that's the odds are less likely that it's going to happen. And this is something that's been not just worked out just by theoretics, but also looking at behaviors of large numbers of people over time who are not on medicines. And then again, we keep talking about an inoculum, the amount of HIV in the fluid of the person who's infected. And of course, condom use. And condoms, when they're used correctly, whether it be a male condom or a female condom, can really negate any risk, even high viral load, anal sex, infected persons on top. That can make a huge difference. And then, as we keep mentioning, again, with inoculum comes along also the predisposing facilitators, such as transmitted infections like sexually transmitted diseases and circumcision. So there's been some calculation. It's really interesting looking back and trying to update this talk. A lot of the data were done a long time ago, and it's almost hard to do these studies now just because of the presence of HIV medicines that make it nearly impossible to look at this. So a lot of the data are old, but I think they hold up. So some of the calculations that have been done looking at people who were not exposed to HIV medicines in places often where it wasn't available or at a time, odds that are given is, the risk of transmitting HIV during a sexual act is 1 in 1,000, but that is really just such a blunt, gross number because it doesn't take into account all the factors we just talked about. So with receptive anal sex, we might see it be more like 1 in 70. Again, all bets are off. A lot of this has to do with, well, who's on top, who's on bottom, who's positive, who's not, and well, how much virus is present. So, but in general, ballpark, we're talking about maybe a 1 in 70. It's certainly not the case that every time someone with HIV has sex with somebody who doesn't have HIV, they are going to transmit the virus. There's this misconception that this is a one and done deal, that this is guaranteed, but it's much like pregnancy. Not every time does that happen. And so I really think putting this into context really helps. Again, early in HIV infection, we see a lot more virus, so the risk of transmitting this to somebody else is higher very early in HIV infection, over the days to week or two after someone's infected and who may not know that they're infected. Much later in the course of infection, we think that the risk starts to drop and go down. When there's genital ulcers, now we're talking about 5.5 times risk. And then non-circumcised men, maybe double the risk. So again, it gives you some sense of some of the risks that may be present and some of the factors that influence it. So as I keep mentioning, viral load matters, and this is a schematic of what happens after somebody is infected, and you can see the amount of virus goes way, way up. So it's like foxes, and rabbits. The foxes just keep going wild, and they eat up T cells, which are our immune system cells. But then the immune system fights back, and there's this equilibrium, this balance that occurs between the immune system destroying virus and the virus replicating and evading the immune system, and we get this steady state that pretty much lasts throughout most of the person's life, unless something intervenes. So it's this critical time period over the first few weeks where people are really dripping with virus and are much more likely to infect people. Later on, a lot of that infectious risk goes down. And this is where we think about people often as transmitters, but really for a lot of folks, their virus level may be fairly low, just naturally. And the time period where they're really more likely to transmit to others is in this early period. And there's some modeling exercises that have been done that says that most of the HIV infection we have in this country disproportionately occurs in people who are early in their HIV infection and who may not know they're infected and are doing behaviors that led them to get infected in the first place repetitively, thus transmitting the virus and propagating the infection over time. And that's not to say infection doesn't occur in people who are chronically infected. It does, but probably a lion's share or disproportionate amount occurs early on in people who are unaware that they are HIV infected. With HIV therapy, the dynamic changes, and you really can get the viral load down to this undetectable level, which is so low that our PCR tests, which are really sensitive, can't quantify or even detect the virus. It's there, but it's just below a level that the test can reasonably confidently indicate it's present or count. So how do we know that when people are in this situation, starting HIV medicines, that they are no longer infectious? Other studies, observational studies from Uganda, had showed us that when you look at people and you categorize them as having high levels of virus, low levels of virus, and in between, just naturally, and looked at their partners, and whose partners were infected or not over time, you found that those who had higher virus levels in their blood were much more likely to have partners who became infected subsequently. And the people who had the very, very lowest viral load didn't infect partners. Their partners remained negative. So these are often serodiscordant couples where one person's positive, one person's negative, and you can follow both over time. And despite counseling and all this sort of thing that you do, giving condoms, some people will still become infected. Almost never did we see infection with people who had low virus levels. So that was suggestive, but not proof. And then this study, which is a landmark study that I'll go over just because it's really interesting for all of us to understand, proved that treating people with HIV medicines did render them not able to infect other people. And this was a large study of over 1,700 couples. So this is a couple where one person's positive and one person's negative. Could be a positive man, could be a positive woman. The study was done across the planet where there's a lot more heterosexual transmission than we see here. So 97% were heterosexuals. And at the time that the study was done, HIV medicines were not recommended for people whose immune system cell count, that's the T cell count or CD4 cell count, for people whose T cell counts were below 500 or so. So this was done at a time different than now, where HIV therapy was fairly rationed or not available. So these were folks who would not get HIV therapy as part of the standard of care at the time in the regions where they were. And so people were randomized to have the HIV positive partner treated earlier than normal with HIV medicine, or delay until their T cell count fell below the threshold, usually about 250 in their country, where you would start HIV therapy. So immediate versus let's wait. And of course, condoms were given, lots of counseling, lots of follow-up, very close follow-up, but you can look at the negative partner and see what proportion of the negative partners in each of these two groups that were randomly selected. People were randomly selected to start HIV therapy or not in the HIV positive person's case, and see how many people actually seroconverted who were partners. So let's see what the numbers showed. Remember, there's a positive partner and a negative partner. Could be a man, could be a woman, two groups. So 886 were randomized to immediately start, 877, flip of the coin, delayed start. Okay, so overall in the study, there were 28 transmissions that were clearly linked from the positive person to the negative person. And the colors represent the gender. Blue is for males of the person who was infected. One of these transmissions occurred from the immediate HIV therapy group, the other 27 from the delayed group. And that one infection that occurred very early on, within the first few weeks of the HIV positive partner starting his HIV medicine, and so probably did not have his viral load suppressed in time to protect this partner. So if you add that up, that's a 96% reduction so this study was stopped early. That's why there were only that number of infections. The study was stopped before more infections could occur because of an early look. So that's really been the proof, and there's other studies that have subsequently verified this, that HIV therapy renders people uninfectious. There's other observational studies. This is a really nice one from Europe, where they looked at large number of men who have sex with men, again, a positive person and a negative person in a couple, over 880 couples, and there were 0 transmissions if the HIV positive partner was on HIV medicines and had an undetectable viral load, meaning again, their virus level. And then even some of the heterosexuals who were enrolled later on, with all different types of sexual activity, you can see there were 0 transmissions. This study's gone on and the numbers have increased substantially, so there's even more confidence. And again, we're just not seeing any transmissions occur when a person is on HIV therapy. This other study called Opposites Attract looked at what happens when you give medicines to a person who is HIV negative to prevent them from getting infected. And I'll show you more information about this in a second. And similarly, no infections that are linked from the positive person to the negative person. So the key message is that there's growing scientific consensus that people living with HIV who are taking effective antiretroviral therapy, that's HIV therapy, whose virus is suppressed to undetectable levels, will not transmit their virus sexually. This has led to this huge movement called U equals U, undetectable equals untransmittable. And this is, started about 5 to 7 years ago and has really taken off as a sort of a catchphrase across the planet. And now even we do recommend to people that they use condoms if they're HIV infected and undetectable, but we indicate to them as well that they may not need to prevent transmission of HIV to an HIV negative partner. Condom use may be useful for other things, pregnancy prevention, also protection from STIs, but when it comes to just transmitting HIV, having an undetectable viral load and staying consistently on your medicines is just as good. And the CDC also has endorsed this for many years now. There was a Dear Colleague letter really reinforcing the same message, that the data support U equals U, and people who take ART, which is antiretroviral therapy, HIV medicine, and again, maintain a viral load that's undetectable, have effectively no risk of sexually transmitting the virus to an HIV negative partner, no matter what kind of sex they're having. So I mentioned PrEP before. This is pre-exposure prophylaxis. So this is different. This is people who are HIV negative taking medicines to prevent them from getting HIV infected. This is sort of one of those best kept secrets, something, back in the days where I was taking taxis and Ubers, getting into conversations about what I do, especially when we were talking about HIV prevention. Many of the drivers had no idea that there was a medicine you can take to prevent yourself from getting HIV infected, but there is, and it's been out for a while, since 2012, and it's 2 medicines in one pill. It's a medicine we use to treat HIV in combination with others, but alone is good enough to prevent people from getting HIV infected. There's been huge numbers of studies all across the planet, tens of thousands of people. This stuff totally works. And this is one of my favorite studies that really put this on the map. I like it because it's just very pragmatic. These are data from men who have sex with men in London who are in STI clinics. So these are guys who come in with sexually transmitted infections, and they were randomized to start taking 1 pill a day of this HIV medicine versus wait, because we don't know if it works or not, and let's just wait and see what more data we get, so people are deferred. And there were only 3 cases out of the 270 people who got the medicine versus 19 out of the 270 who didn't get the medicine. So that's a huge reduction. And oftentimes what we see is that the cases that occur on PrEP are not breakthrough, but people not taking the medicine, mostly every day. That's a huge reduction, and that's fantastic. There's pragmatic data as well from real-world studies and observations. Here's data from Kaiser Permanente in San Francisco here in the United States that looked at over 1,000 people who were referred for PrEP. 80% of them followed up with their appointment. 82% of those started on PrEP. They were followed up for close to 400 collective years of follow-up. And there were lots of STIs, so we know people were having sex. It wasn't that they became celibate. Just because they started this, HIV protection medicine, and there were 0 new HIV infections among the people who used. So again, just huge accumulation of data. This study just came out the other day. This is from Paris, and it really just shows you that this is not, this is not far-fetched. This may make a huge difference. This is a study where people in the Paris metropolitan area, mostly men who have sex with men, enter the study and can take PrEP every day. There's also a way to take it on demand where you take 2 pills 2 to 24 hours before sex, and then 1 pill the next morning and 1 pill the morning after that. So 2-1-1 it's called. So this is very popular in Europe, or you can take it daily, it didn't matter. So large numbers of people, we're talking about 8,800 people in each of these arms, so huge. And the outcome of the study is decrease in HIV incidence, new diagnosis in the Paris metropolitan area. They're not looking at just to see what happens to the people in the study. They want to see, does this make an impact for the city? And they've been following people now for a while. And so far, there's only 3 cases of HIV out of 8,800 people in each of these arms, only 3 in each arm. And they're all basically taking their PrEP. And it's just remarkable. And that's just unprecedented. These guys have plenty of risk. When you ask them about sexual exposure, here's condomless sex. Most of them are having condomless sex, and it seems to be increasing in receptive anal intercourse, just very high. Number of sexual partners is not, low, and, number of sexual intercourse episodes in the past prior week, 4 weeks. I mean, so again, I think that this does explain a little bit that, PrEP works. And here in the United States, we have seen a decrease in new diagnoses of HIV. Was around 50,000 or so earlier last decade. Over time, that started to drop down. Now we're closer to less than 40,000, at least before the pandemic, might be even lower now. And while there's other things that have come into play since 2012, like treatment as prevention, like changing demographics, PrEP availability in 2012, I think has also hastened some of the decline in new HIV infections. There's other types of interventions that are important that you hear about and that I think are important to know about. So certainly after an exposure, whether it be a healthcare worker or it be a correctional officer or it be a law enforcement officer who are exposed, there is post-exposure prophylaxis. So that's giving somebody HIV medicines, a full complement of HIV medicines after a significant exposure. We have lots of rules, and there's pages and pages of this, of what counts as a significant exposure and what doesn't. In the hospital, we see this all the time. As we talked about, there are infectious fluids, and here they're written in red, and there are non-infectious fluids. So you do not see spit. Spit is not here. So in our hospital, if a medical student or a nurse or a clinician, another clinician, a physician says somebody spit at me, they will not get post-exposure prophylaxis from occupational health. But if it was spinal fluid or synovial fluid from the joint or blood, then we would think it was a significant exposure if it got onto a shiny surface. If it's not on a shiny surface and it's not an infectious tissue or fluid, you're not going to get post-exposure prophylaxis. And I think that's a good guideline for what we do for ourselves in our occupation, for understanding what the risks are outside of the healthcare setting. So wrapping the HIV part of this up, this is kind of putting it all together. So rules regarding HIV for lawyers, kind of summing it all up. All transmission of HIV requires a source to be infected and a susceptible host, and the infected source has to be infectious. Most sexual encounters are, of course, concordant negative in the world, in the universe, negative, negative. There are positives who have sex with negatives, and the efficacy of transmission in that case is determined by lots of factors that we went over. So it's not so easy, it's complicated. Just because you're HIV infected, then we have to start thinking, well, what's your viral load? What kind of sex did you have? Are you on HIV medicines? Is the person you had sex with on medicines that prevent them from getting HIV infected? All these things have to be thought about. Are there sexually transmitted infections? What about circumcision? Most sexual transmission of HIV occurs in newly formed relationships. That's especially when the HIV positive partner is newly infected and at the maximum risk of transmitting their virus to other. Longer term relationships with an HIV positive person certainly can result in transmission, but with generally less efficacy and efficiency than we see with people who are newly infected. And then condoms work extremely well for preventing HIV transmission. Part 2, HIV therapy reduces infectiousness greatly if the medication is taken. So there will be circumstances where someone says, well, I'm on HIV medicine, so thus U equals U, I can't transmit the virus to this person I had sex with, but it matters whether or not they're taking the medicine and if their viral load is suppressed. All bets are off if the medicine is in their cupboard or in their glove compartment and not in their body. Part 3, PrEP works. So someone on PrEP really becomes, for all practical purposes, if they're taking the medicine reasonably well, protected from infection. So going to shift just very, very briefly to COVID, and then we'll open it up for questions and discussion. So what about COVID? The principles we've laid out and the principles I've been talking about and others for many years regarding HIV completely apply to COVID. There are huge differences though, right? Because the transmission route for this disease is very different because it's airborne, right? So we're talking now not about sex, we're talking about being in a room proximal to somebody else. But the same sorts of things have to be thought about. There are ways to transmit it, and there are ways that you can't. You need an infectious person, and you need a susceptible person, just like we talked about with HIV. So in this diagram, again, you can see you need somebody who has enough virus that they can produce a cloud that could then go through some distance, transmit to somebody who's susceptible. That means they've not been infected before or vaccinated. If they have been infected before, they may very well be immune. And if they're vaccinated, they very, very well might be immune. So you need the combination, the perfect storm, if you will. Unfortunately, up until now, and even now, there's been a lot of perfect storms of people transmitting infectiously to others. We know that it's a droplet, but there's semantics here, droplet, aerosol. You know, the smaller the drop, the more it could transmit. But remember, inoculum, 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 the smaller the little particle, the less virus is present. So while some clever scientists can show that she can detect a very small particle 20 feet away in a room that has SARS-CoV-2 virus on it, that there may not be enough virus there to infect any human. There could be indirect contamination of surfaces, and as we've all learned, that seems to be a very minor way that this virus is transmitted. This is transmitted proximal from person to person. And as we'll talk about, a lot of folks, just like with HIV, a lot of folks who infect others are asymptomatic and don't even know that they have it. There's no evidence for blood or urine or other body fluids really transmitting the virus to others. This looks horrible and complicated. I'm just going to really highlight this orange line. So this orange line indicates infectious virus that you can isolate. This is real living virus that you can put in a culture and it grows on a plate. Okay, this dotted line here is when symptoms start. So somebody is infected, let's say a week before their symptoms start, you can start to see the amount of virus in their respiratory tract increase. So it may be fairly high right at the point where they start to get symptoms. This is the problem. People can asymptomatically transmit COVID to others. And there are young people, often like college students, who don't show any symptoms at all and go through the same process. Then over time, and really very short period of time, infectious virus goes away in about a week and a half. In studies where we find people who are symptomatic just for a few days, study them, swab their nose, and you can see it go down. Now, PCR can sometimes pick up genetic material even way far out. So that's why you see this blue line. Swabs can be positive long-term, but real infectious virus is probably pretty short-lived for most people. We do know that that leads to something like this, and there's been lots of these kind of analyses that have been done. You've seen this before, where there's just this like perfect storm again of somebody who's infectious, a ventilation system that facilitates transmission, like an air conditioner pushing particles that are infected out this way towards these tables, but no one over here getting infected because they're just too far away. So we know that this kind of thing can make a difference, and this is a real depiction of a transmission event. This is the same thing on planes. We've seen lots of good animation showing how there's very limited transmission, vertically across the plane, but more horizontally as the air system circulates this way rather than that way. So we know a lot about how this virus is transmitted. We also know how it's not transmitted and what makes a difference. And there's a cottage industry now in these kinds of studies where mannequins with generating droplets have face masks of different type covering them, and we can see the effect on decreasing the spread of the virus in the air, and this stuff works. I mean, there's no study that showed that this doesn't work, and you've seen the same sort of data, how even some of these bandanas and cotton t-shirts and stuff like that, they don't work as well, but they do work. Again, the parallels to HIV are pretty clear. Barrier protection works. This is not exactly a condom, but in many ways sort of like that. And it's a physical barrier to the spread of the virus from, the transit of the virus from one person to another. Makes a lot of sense. I don't think it has to be too controversial. And then there are even studies like this, meta-analyses, which are studies of studies, that show if you look at the accumulated studies to date and look at things like physical distancing, if you look at face mask versus no face mask and eye protection, these are in healthcare settings, they work, and they work even better in combination. So I'm going to stop there. I covered a lot of material. There may be questions about stuff that I didn't cover that I may be missing, and I'm certainly open to hearing more of your thoughts and maybe some of the questions you have in dilemmas in real life. So I'll stop there, and Jada and Sasha, I'll stop sharing too, if I could figure out how to stop sharing my screen.
Great. Thank you so much, Dr. Wohl. And I will at this time remind folks that if you want to ask the doctor any questions, there is the question feature on the right side of your screen in the drop down. You can go ahead and drop a question and we'll read it to Dr. Wohl. But it does look like we already have a few, if you don't mind answering them. The first one is asking for clarification when you mentioned that anal sex is the top way to become infected, and they just wanted to clarify if that's correct.
So sexual transmission on the planet, #1 way that HIV is transmitted. Yes, more than half of new infections that occur in the United States are among men who have sex with men. And most of that is going to be anal sex. So yes, that is true. Now, women do get infected, and women can get infected vaginally or anally. Women can get infected through injection drug use. But by and large, over 50% of the transmissions that we're seeing in the United States are among men who have sex with men, and anal sex is the dominant way that men who have sex with men have sex. So yes, that's true in the United States. Worldwide, heterosexual sex is the #1 way that we see transmission. That's led obviously by what we see in sub-Saharan Africa and in Asia.
Understood, thank you. Our next question, we have an attendee who would love if you could just elaborate more, talk on hepatitis C and transmission there.
Hepatitis C is different. Very good point. So we talk a little bit in my field about the rule of threes, which again is blunt and not completely precise, but if we say that from a needle stick, let's say, there's a 1 in 300 chance that HIV could be transmitted with a really substantial needle stick in the hospital. That's, high viral load patient, good penetration into the skin with a hollow bore needle. For hepatitis C, it's about a 1 in 30 chance. So it's much more infectious. It has a much more avidity for the blood and a high concentration. Interestingly, for hepatitis B, it's 1 in 3. So B as in boy, 1 in 3. Hepatitis B is extremely infectious. And when people are infected with hepatitis B, they are teeming with hepatitis B. There's loads of hepatitis B in their blood and in their body. So hepatitis C is serious. It is very catchy. But some of the same things apply. So if you're hepatitis C infected, but your viral load is reduced because you're on treatment, and treatment is given for a short course to actually eliminate the virus, or the virus has been eliminated, you are no longer infectious. We don't have PrEP and we don't have a vaccine for hepatitis C, but yes, hepatitis C is more catchy.
Okay, and on that note, I think we have a related question. If you could clarify transmission risks around Hep A, B, and C, and whether there are vaccines to prevent these and what kind of treatment is available.
Yeah, really great question, because this gets very confusing for people, so it's good that you asked. So yeah, we have a little bit of an alphabet soup when it comes to hepatitis. So Hep A, just taking it in alphabetical order, Hep A is a virus that does infect the liver. It's something that we get from contaminated food. It can be during sex. Inadvertently, there's fecal oral transmission, but most of the fecal oral transmission that occurs is from somebody's hands making some food. Little bit of the virus gets into the food and people get sick at a restaurant or if you're traveling. The good news about hepatitis A is that it's a fairly wimpy virus compared to B and C. So we can get rid of it. Most people do fine with it. Very, very rare that it causes somebody liver failure or anything like that. It's self-limiting. You don't need treatment. It goes away. There are vaccines for it that are very effective, and that's what we sometimes take before we go to travel to a place that has hepatitis A commonly there. So hepatitis A, usually not a problem. It's a problem if you own a restaurant and you have an outbreak, but that's the most major thing. Hepatitis B is a bigger deal. Hepatitis B is not curable, but the good news is the majority of people who get hepatitis B eliminate it themselves. So about 80% of people who are infected with hepatitis B are fine. It's transmitted largely the same ways as HIV, through sex, through sharing of works, and mother-to-child transmission is one of the more dominant ways of transmitting it, especially in Asia. Tattoos, again, if you can imagine that it's 1 in 3 chance with a needle stick compared to HIV, which might be 100-fold less likely to be transmitted, you can imagine there's just a lot of it. There's many more people with hepatitis B, so it's very, very catchy. And that's why we're fortunate in this country, because we do have great hepatitis B vaccines, and all little babies now, since like 1988, are vaccinated. And so we really are effectively eliminating hepatitis B in this country. That's not been the case in other parts of the world. And so we do continue to see that. But hepatitis B is something that, that is treatable, not curable for people who are infected, that 20% who just can't fight it off by themselves, but medicine could really suppress that. Lastly, there's hepatitis C. We do not have a vaccine against hepatitis C. It is more common than HIV. Maybe 5 million people in the United States have hepatitis C, compared to about 1 million people have HIV, and less than that have hepatitis B chronically. Hepatitis C is the opposite. About 20% fight it off and 80% have chronic infection. No vaccine, but there are cures. So we have hepatitis C therapy. You've seen the commercials where people can take a medicine, and it's like 90-something% of people who take it faithfully can get cured. So these are all really important, and they're big deals. The number one way that we see transmission of hepatitis B in the United States and hepatitis C in the United States is really going to be injection drug use. That's where we see it. 80% or so of people who inject drugs are hepatitis C infected. So that's why we see a lot of it in corrections. There's a lot of needle sharing, a lot of tattooing. There's also some data that sharing snorting material like straws can also transmit it through the shiny surfaces on the inner part of the nose. But the good news is hepatitis C is largely curable now. And that's a relatively recent event. That's just over the last 5 years or so.
Great, thank you. Looks like we have a couple more. We're going to circle to a different tack here and asking, could you speak a little more about what happens to viral load / infectious ability when a person living with HIV does not take their antiretroviral therapy meds regularly?
Yeah. So what generally happens is not long after somebody stops their HIV medicine, the virus will start to reproduce again. So HIV medicine that we have now is birth control for the virus. It doesn't kill the virus on contact like RAID. It's not bleach. What it really does is it prevents the virus from making copies of itself. It gunks up its reproductive system. And so what you have is this, there was this attrition, right, between the virus and the immune system, and there's this stalemate. And now that we don't let the virus replicate, the immune system can get the upper hand and the virus level drops. But once you stop the birth control for the virus, it can start replicating again. And there's virus that's inside of some of our cells. And when that cell wakes up and turns over and makes more parts of itself, it makes more of the HIV. So these cells are deep inside our body. They're in all parts of our body, in our brains, in our lymph nodes, in our GI tract. We can't get rid of all of them. We haven't found a way to do that. So once you take your foot off the snake, it just starts to reproduce. Now, how long that happens is very interesting. And this gets into some of the more wonky inside baseball parts of this. But for some people, it's right away. But for others, for reasons that are not completely clear, it may take weeks before that virus level jumps up. But it's very measurable. We certainly, I see plenty of patients who, for one reason or another, stop their medicines, whether because of some problem on their end, or not infrequently some problem at the pharmacy or insurance. Unfortunately, probably insurance companies are the #1 reason people end up stopping their HIV meds, and then their virus level goes up. And I would say on average, it takes just a few weeks, maybe 2, 3, 4, 5 weeks, that virus level goes up. And now, as you are probably thinking, they become infectious where before they weren't.
Great, and then let's see, how easy is it to transmit any form of viral hepatitis via spit or urine?
Yeah, so not very effective at all. Spit and urine. Urine is completely sterile. So urine is sort of like distilled through this incredible filter of our kidneys. And so germs just don't go through it. Any germs that are in the urine are what's really at the very, very tip of the tract that carries the urine, the urethra. So we don't see, very rarely is there, and when someone has an infection in their urine, they know it, right? Because you get a UTI. So it's a sterile substance. Spit as well. The interesting thing about spit, so why not spit? You know, we talked about how virus gets into the vaginal vault or into the rectum, and there's shiny surfaces, and HIV is transmitted and it can be infectious. Why not the mouth? The mouth is really interesting. There's so many antibodies in spit. There's really good protection in the mouth. There's the tonsils, there's other lymph tissue. It is like a fortress. So we just don't see, like in tears and spit, we just don't see viruses really very easily transmitted through that from the blood. Now, there are viruses that live in the mouth, obviously, like HPV or herpes simplex that could be there transiently. That's a little different, but that, you know, spitting at someone is not how you're going to get those. That takes a little bit more prolonged, intimate contact. But yeah, I know the spitting from somebody to somebody else, that's not how people get HIV or hepatitis B. Then you start getting into, well, is there blood inside of that? If there's no visible blood, I'm not worried. If there's visible blood, now you're talking about spitting blood, and that's different. Blood carries these viruses, but if you don't see visible blood in spit, they are not infectious for these viruses.
And I think you were kind of getting into this already, but we had an attendee ask, what STDs can one get from saliva or kissing? So just kind of broadening it out a little bit.
Yeah. So there's a bunch of things we can get from kissing. Fortunately, they're not too serious and not too common. The most common things we do, we trade herpes simplex all the time, HSV1. So there's this somewhat no longer true dichotomy between HSV1 and HSV2. So HSV1 was considered, you know, what we get cold sores in our mouth from, and HSV2 is what we get genital ulcers from, and that's when we say, I've got herpes, we think about HSV2. Turns out that there's a little bit of mixing and matching now, where some people can get fever blisters on their lips, and that could be HSV2, and we see genital ulcers from HSV1, and really just if you look just objectively, epidemiologically, and anthropologically over time, there's just more oral sex happening at a younger age over the last 30, 40 years. So we're just seeing more mouth transmission of viruses that live in the mouth going to the genitals and vice versa. So that HSV would be the number one thing. EBV, which is Epstein-Barr virus that causes mononucleosis, that's something we know, and that's kissing disease, right? So people have heard about that before. And that's also in a big family called herpes viruses, of which herpes simplex is part, and also EBV is part, and even the shingles virus, the chickenpox virus, is also can be transmitted that way too, through the saliva. These are all viruses that live in the body, they never leave the body, and they can be transmitted oftentimes through the spit. But really, some of the more exotic things, the things that we're worried about, really spit doesn't do it. You know, so it's hard to think of something where somebody can spit at you and really harm you. Of course, you know, with COVID, and I think some of the sort of fortunately rare events of people coughing or spitting who have, you know, say I could be COVID infected and threatening other people, that would change things. The flu, anything that lives in the throat and mouth, flu, you know, all these respiratory viruses, you know, theoretically could be transmitted, I would think, when someone's spitting at somebody, but I think it's more the droplets from the lungs that would do it rather than the spit. So again, short list. I really think it's hard to come up with a good evidence base for spit being able to transmit to somebody any of the more serious viruses that we're talking about. Even herpes or some of these things, you would have to have the perfect storm of there being enough of the virus getting in that spit, getting into somebody else's mouth pretty much, living in that mouth and staying in that mouth. I mean, it's just the probabilities start to become infinitely more unlikely.
Great. And it seems like you have kind of a supernatural way of anticipating what the next topic might be, because we do have a question perhaps to round out today's webinar about COVID. So can you share the transmission risk of COVID in an outdoor setting where people are wearing masks, specifically larger groups of people?
Yeah, this is a great topic, and I find it fascinating. The data are really getting stronger and stronger. Outdoors is a completely different ballgame than indoors. That's one thing. I mean, the ventilation that just occurs, the flow of air just changes the dynamic from indoors. Indoors is horrible when it comes to COVID transmission. It just facilitates it so well. So that's number one. Number two is masks. Masks, and plus being outdoors, especially sunlight, outdoors, some airflow. Now you're starting to talk about really low risk. And if you add in distancing, it's not going to happen. So I'm sorry. I think that there is a big difference between a rally where people are distanced at least 6 feet, wearing masks outdoors, and a rally where people are bunched together, not wearing masks, and they're outdoors. Those are two very different dynamics, and I think they matter a lot. So I would rather see people indoors, 20 feet apart, 6 feet apart, whatever, with masks on, praying, than see a whole bunch of people, gathered outside without masks. It's just very clear what works and what doesn't work. I work out with a bunch of guys every morning at 5:30 in the morning, and we decided, mid-pandemic, after we took a break, we can do this, but because we're running and we're huffing and puffing, we're going to maintain at least 12 feet distance. We're going to wear masks. We're not going to share any equipment, no touching anything. And we've gone through the whole pandemic doing that. This is like 1,400 people in our area. There's been no transmissions that have occurred without there being another explanation, not our workout. So I'm practicing what I preach. I think outdoors with masks and distancing, I won't say the risk is zero. Anytime you leave your house, the risk is no longer zero, but it's infinitesimally small.
Great. Thank you so much again, Dr. Wohl. I know that our attendees have appreciated your time and your expertise and how concise and clear you've been with the evidence and the information that you've presented us. So just want to thank you again for all your hard work and your time today.
Thank you.
Absolutely. And with that, we are going to wrap up our webinar at this time. Attendees, you will be able to view this recording later in a few business days. It will be up on APA's website, so you will be able to rewatch it. Additionally, we will be sending out a post-webinar survey. It just helps us evaluate how we can do better for you. So just takes 2 minutes of your time. And once again, thank you all so much and have a great rest of your day. Thank you.